As you all know, our featured speaker tonight is Doug Boysen, CEO and President of Samaritan Health. And Doug, do you have any starting remarks?
Yeah, I do. And thank you for having me here tonight.
Can you speak louder, please?
Yeah, thank you for having me here tonight. I appreciate it. Mike asked me to come tonight. Dr. Huntington asked me to come to talk about the financial challenges in healthcare right now, just in general, and maybe how it's impacting Samaritans. So I don't have a formal presentation. I have a few thoughts. I'll go through that, and then happy to open it up to questions and just have a discussion. I think that'd be more productive. Really, since the start of the pandemic, and actually even before that, but I think it's been even magnified since the start of the pandemic, healthcare organizations across the country are really struggling. In particular in Oregon, they're really struggling right now. And I don't know how many of you have been reading in the news, but even the big systems like Providence Health, I think they've lost like a couple $2 billion. It's hard for me to even fathom that in the last 3 to 4 years. OHSU's losing money, Legacy's losing money. Asante down in Southern Oregon is losing money. Peace Health, which is the Riverbend Hospital in Eugene, they're losing a ton of money right now. And for Samaritan, we've been able to be about break even through all of the pandemic, except the last 5 or 6 months have been really rough for us as well financially. So we're maybe a little late to this financial suffering party, but we're there right now. A lot of people, especially even doctors, are asking me, why is this happening across the state of Oregon right now? And I think it's a whole host of issues, and it's actually pretty nuanced. I think there's some issues like just a general workforce shortage in healthcare in Oregon across the country. We're having to pay for a lot more. Rather than able to get employees, we're paying a lot more contract or what we call agency help, which is a lot more expensive. There have been some massive cybersecurity attacks in healthcare. There was a really big one called Change Healthcare. It's owned by United Healthcare. They help with the billing process for most healthcare organizations in the country. That system got hacked and it shut down ability to bill, including us and a lot of other healthcare systems across the country, which hurt a lot of organizations this spring. And then payer issues. Insurance companies it's getting more and more combative, and it's getting harder from a Samaritan's perspective to get paid what we think we're owed. So those are some of the issues. I'd say the fundamental issue for Samaritan and probably the Oregon healthcare organizations is just the level of government reimbursement that we have compared to the total reimbursement that we have, given the high inflationary period that we've all experienced personally and organizationally the last 3 to 4 years. About 80% of who pays us is either Medicare or Medicaid, or it's uninsured population. That's about 80%. In the last 3 or 4 years, like any business, we've seen our supply costs go up drastically. We've seen our wages go up drastically. Utilities have gone up drastically. But for that 80%, they're still paying us the exact same rate as we were before, right? So our revenue, what we get paid, has stayed here, and our expenses keep going this way. Now, we can give price increases to the commercial insurance companies. We can negotiate that. With the government, that we can't. But that's only about 20% of who we serve. And so there's such a big gap there. That's not sustainable to push that all on that 20% either. So therein lies the crux. And that's what most healthcare organizations are faced with in Oregon. And when I see that an organization is really struggling, I know off the top of my head, they're doing a huge amount of Medicare and Medicaid work. And that's what's leading to it. I think in Oregon, it's magnified even a little bit more in that in Oregon, in the last 3 years, we've gone from 1 million people covered under our Medicaid program to 1.4 million covered. which I'm all about people being covered. I do believe that everyone has a right to being insured. But Medicaid pays so low, so little, when we're seeing more of the population covered under Medicaid. That's just more and more services that organizations like Samaritan are doing, where we don't get compensated close to what our cost is to provide those services, which makes it more challenging. And then we're seeing independent clinics like the Corvallis Clinic and the Ben Memorial Clinic over in Central Oregon not being able to make it. Then they're being bought out by these really large, either PE-backed firms or really large stockholder-owned for-profit organizations that see less and less Medicaid. So more of that's getting pushed on the nonprofit organizations. And that's our mission. We're always going to do it. We're always going to see everyone regardless of ability to pay. That's our DNA. That's why we exist. But financially, my point is it's getting more difficult. I think in the short term, what we're going to see in Oregon is we're going to see more problems for people accessing healthcare. I think, we're seeing more independent clinics close. We're seeing more providers retire more quickly than anticipated. Because our reimbursement rates are lower in Oregon, it's hard to recruit doctors from other states into the state because, they don't want to take a pay cut. We're probably going to see in Oregon, hopefully not in our area, but we're going to see service lines being closed that we haven't seen closed before. In Baker City, they stopped doing maternity care services, which I find unbelievable, because if you're a mother having a baby in Baker City, you can't deliver that now at the Baker City Hospital. So you either have to drive east to the first hospital in Idaho, or you have to go west to La Grande. Either way, that's a tough drive, especially in the winter. And Mount Hood Medical Center, which is up in Portland, owned by Legacy, they decided that they were going to close their maternity care services. They're in Gresham. The state stepped in and didn't allow them to do that. And then we saw Peace Health literally shut down the University Hospital in downtown Eugene. So there's things like that going on right now that are a little unsettling. I think we're going to see more mergers and acquisitions. We saw Corvallis Clinic get bought by Optum. Optum is owned by United Healthcare. OHSU is in the process of merging with Legacy Health right now. So these are the two big organizations. They each have a children's hospital. They each have level 1 trauma center. They're coming together because both of them are losing money right now. And then maybe more close to home, Santiam Hospital, which is a small rural hospital in Staten, Oregon. They're decided that they're going to join into the Samaritan system, which I think is a good addition for us. And I think it's good for them. They're nonprofit like us and mission minded. So I think it makes sense. And frankly, they're not going to be able to make it on their own, unfortunately. And I think that's too bad. And I realize everything I'm saying is really negative. I'm actually a really positive guy. I always look at the glass half full, but there are real challenges in healthcare right now. And I think that's probably what you're feeling from healthcare providers around the state. So with that, that's just kind of the state of what's going on in healthcare right now. I'm happy to open it up for questions, comments, concerns, or any other questions that you have about Samaritans.
So before I start calling on people, if you could wave a magic wand.
Yeah.
What one or two, where are the first or second changes you would suggest making?
Well, I think we want, so I believe strongly in our Medicaid and our CCO program in the state of Oregon. I think it's probably one of the best programs in the state, or in the country, I'm sorry. But it is wildly underfunded. We have some of the lowest Medicaid rates in the entire country. And I think for folks that have Medicaid insurance, it's not fair for them to have a card. That's not healthcare. But what we're seeing in a lot of spots in Oregon is that someone may have a card, they may have insurance, but there's no one willing to treat them because the reimbursement rate is so low. So I think the state has got to address the Medicaid rates. I think if they could pay a little bit more, and I'm not even just talking about Samaritan from this perspective. I'm just talking about all the psychiatrists out there, the independent psychiatrists, all the independent primary care doctors out there, that if the state could pay a little bit more for Medicaid, which out of the general fund of our state government, of our budget, out of almost all states, we put less out of our general fund into Medicaid compared to all other states. So we just have not made it it sounds crazy because I think Oregon's a really progressive state, just have not made it a priority funding healthcare in Oregon. Another example would be, we have one of the highest rates of substance use disorders in our population compared to any other state. And we have, I think, second to the last as far as treatment facilities compared to other states for people with substance abuse problems. And there's just some fundamental resource access and dollars going into healthcare in Oregon. So I think we got to make it a priority and fund it if we want better access.
Okay, thank you.
Yeah.
Karen,
Yeah.
Follow-up to your comment about the Medicaid funding. Perhaps I don't understand the cash flow that occurs here.
Mhm.
What role does the federal government have in funding the Medicaid program in Oregon versus the state legislature? Where do we have to apply pressure to increase that reimbursement?
On that, the state, the federal government does put in money and they do supplement it. But what they put into Oregon is comparable to other states from what I can tell. What Oregon puts in, though, comparable to other states is less. So where we're really falling short right now is at the state level, from my opinion. Yeah.
okay, thank you. Anybody online with a question, please raise your electronic hand. I think that's the best way for me to see you. Is there another question in the room somewhere?
There's one over here. Yeah.
Oh,
Yeah.
Alex.
So with respect to OHSU and Legacy.
Yeah.
I saw Legacy was losing money, but there was a one report article saying OHSU actually made a profit, like $45 million or something in the last, whatever the last period is.
Oh, that could have been.
So-
They had been losing. I think they lost about $60 million in the period before that, but that could be. I don't know. Yeah.
So is that indicative of anything? Is that could be a possible trend reversal, or is that just like a one-off?
It could be. I hope that it is. OHSU, I think it's a really well-run organization. I respect a lot of people up there. They do get additional government assistance, so I think that helps them compared to other systems in the state. I hope, it could be that they're able to manage some of their costs better. I think that's a really good sign. If that's the case, I haven't seen that. I think that's a good sign for Legacy. Because at one point when they announced that they were both losing money, and I was like, oh, you add that up, it just seems like a greater loss. But I suppose there's some economies of scale with them coming together, and there's some efficiencies. And what I worry about with those two organizations coming together, and I respect them both, but the state needs the 2 level 1 trauma centers and we need the 2 children's hospitals. I really hope that they don't come together and say, well, we're just going to have 1 children's hospital now, 1 trauma center. Maybe that's okay if they have enough capacity in them, but right now we need them both. We're also, that's another thing. I think we all were very proud before the pandemic that Oregon, for our population, has, I think other than maybe Washington, the state of Washington, we have the least amount of hospital beds for our population. And we thought, well, that's great because we're keeping people healthy, and people are just generally healthier anyway in Oregon, and we don't need all these hospital beds. But where Oregon and Washington really felt it was during the pandemic, when we all of a sudden had just a dramatic part of the population that got sick in a very condensed period of time, where there just were not beds. And I'm sure you all, have heard stories where we did not have beds in our entire system, or we took a transfer at one point from Anacortes, Washington. So that means that there was not 1 hospital bed in Seattle the entire city of Seattle, in Olympia, or actually in Tacoma, in Olympia, in Vancouver, in Portland, and in Salem. Which I at one point tried to kind of add it up just with some loose math about how many hospital beds are between us and Anacortes, and it was something like 8,000 beds, and they were all full at that point in time. So I think we're probably gonna have to add some beds. At Good Sam, our main hospital here in Corvallis, we have plans to add probably about 20 beds next year and another 20 beds the year after that. I think the pandemic has just shined a light on, maybe we're a little bit behind, and it's an aging population too. So I think that's adding to it.
Can I just follow up real quick? Though?
Yeah, sure.
Not to be too I'm just wondering though, because you said, oh, why is OHSU and Legacy merging and we're both losing money? Well, you're losing money now and San Am was losing money.
Yeah.
So that kind of contradicts.
Yeah, I hear you. OHSU, well, Legacy's been losing money for like 3 years, and OHSU was losing money for quite some time. Maybe they turned it around. As I said before, we've been okay except for like the last 5 months. And San Am lost money last year, but they're making money this year. So, with them, they literally, as a standalone hospital, can't afford the electronic medical record system that they need there. Epic is what most hospitals use in the state. And frankly, none of our 5 Samaritan hospitals could afford that on their own. So if you put 5 hospitals together and now another one, and you split the cost of like that EMR system across 6 hospitals, it becomes affordable. And that's kind of where the economies of scale come into play, which I'm sure OHSU and Legacy are hoping for as well. The medical technology side is, it's expensive, and as a standalone independent hospital, it's just really hard to have the latest and greatest. And what we find, and they've found, there's a thing called like a Da Vinci surgical robot, which we have 2 at Good Sam and 1 at Albany. Lots of procedures are done with these robots now. They're actually pretty amazing, but they're wildly expensive. And if you're various types of surgeons being trained today, and you're in medical school, and then you go through your residency program, these companies have done a very good job of getting ingrained into these residency programs. And so the residents are trained on these robots. And so when they are looking at where they're going to land permanently, if they're looking at like the hospital up in Enterprise, Oregon, up in, I think it's the Wallowa Memorial Hospital, they don't have a robot. So a young surgeon may say, well, I don't feel comfortable doing that by hand anymore. I'm not going to go up there anymore, or I'm not going to go there. So it just even makes it harder for those rural places to recruit these young doctors in that particular case. I think on the other hand, a place like Wallowa, or a place like Lincoln City or Newport or Lebanon or Staten, Corvallis, Albany, frankly, all of them, they offer a better quality of life than maybe a bigger city. On the positive note, because there are positives, we've never had better physician recruiting than we've had probably in the last few years. And I think it's because doctors that were in the large cities during the pandemic just decided they wanted to do something different on the backside of the pandemic. So that's actually helped us in our area. I don't think it's been quite the same up in Portland, but we've actually benefited from it. Yeah. And don't worry about being a contrarian or pushing back on anything I say. Sometimes I'm wrong. Yeah. Go ahead.
You have a background in law.
Well, I have I have a master's in healthcare administration, and I have a law degree as well. Yeah.
So the question I have is,
Yeah.
could the Department of Justice successfully sue for practicing medicine without a license, a corporation practicing medicine without a license?
Maybe, I guess it would depend how the corporation is influencing the physicians. There was a proposed bill that I think is coming forward again in this 2025 legislative session that it might be as a Representative Noce that has been proposed. I can't remember the legislator, but
Bowman.
Bowman, you're right. Bowman, that's right. That's proposing to have, there's been like attorney general opinions out there around this, and the general rule in Oregon at least is if you're healthcare system with a hospital and you have doctors employed there, that's one thing. If you're a medical school like OHSU or Western University, that's okay. But the rest of it was kind of murky. What this proposed legislation is really to try to prevent these private equity backed ventures, which that's a real thing that's happening all over the country right now, is these PE firms are buying up lots of physician practices all over the country. I honestly still don't understand the endpoint on that. I don't know what the end game is on that and what they're trying to accomplish, but nonetheless, it's happening. And at least what I hear from doctors is that, it sounds good. They usually pay a very handsome price selling when the doctors are selling it. And they're told that they'll, make everything more efficient and then just get out of the way. But a lot of times it doesn't end up that way, that they do get pretty intrusive. I don't know if that's always the case. I've never worked for one of those firms, so I don't know any of that firsthand, but I do hear that. Yeah. Yeah.
Question.
Yeah, go ahead.
So since it sounds like this healthcare financial crisis has been written in the cards for some time, I'm curious what lobbying or legislative advocacy work, if any, Samaritan has participated in.
Yeah, we do most of our work, because we are a 501c3 nonprofit, so we have to be careful, because we're tax exempt, we can't advocate for certain candidates that we think represent, but if it's issue that directly relates to healthcare, then we can speak up about it and we can work through our hospital association on that. We have been big proponents of higher Medicaid reimbursement, making sure that the state is adequately funding the Medicaid program. We want to keep the Medicaid program. We think it's a fantastic thing. The last I heard is about, I think the latest is 96% of Oregonians have insurance now, which is a great thing. But I will qualify that with, if you have an insurance card, that means nothing if you can't get the care. So you got to be able to get the care. So maintain the Medicaid program and fund it adequately. Anything around the workforce shortage issue, anything that we can do to increase the throughput of nurses in the state or doctors in the state, we believe that would be very helpful as well. Those are probably the biggest things that we've been advocating for.
Yeah, we're also in that same position as a 501c3.
Yeah.
Our little organization, we can't advocate for any candidates.
Candidates, yeah.
I wanted to bring some cards here tonight that have a certain candidate's face on them, but in any case. Let's see, I haven't seen any hands online. I'm sort of bouncing back and forth on one line here, but
Can I
go ahead.
Well, I respect this group in what you all do and what you're advocating for immensely. And I've said this to Dr. Huntington and other leaders of this group, because I have sensed, I think, Mike, one of the first times we sat down, and I don't know necessarily, I've worked for Samaritan for quite some time. I've been the CEO for about 6.5 years, coming up on 7 years. When Mike and I've known Mike a long time, I've always respected him. But I think there was a feeling at one point that somehow Samaritan was, standing in the way of what you were all trying to do. And that's not the case. Samaritan, again, we're not a political organization. We are dropped into this US healthcare system framework, however the voters decide it is going to be. And it's our mission to provide care to everyone the best that we can. And so I view what you're all doing is really helpful. And I think, getting the public to understand what you're trying to do and the reasons for it, and legislators to understand it, is great. I think when you look within the healthcare organizations in the state of Oregon, I hear healthcare organizations talking more about a universal payer type system more than I've ever heard that being discussed. So I think generally, even folks in healthcare that may even historically have been against some of the concepts that you all talk about, we talk about, I think there's a more openness to that. I think especially as it gets more, it's always getting more complicated, more complex, and the relationships between payers and providers seems like it's, you know, at times it's getting more adversarial all the time. And that does nothing but hurt the patients and the members of those insurance companies. So I think there's an openness to it. I think a couple of the hurdles, this is just me saying, we're working in healthcare, is I think the scary thing is if a universal payer is just all government and paying at the rates Medicaid is paying right now, it's not sustainable. Like, and I think that's the fear, is that if I get to a point where I can no longer, and it's already hard, but if I can't recruit any more psychiatrists, I can't recruit any primary care physicians because I can't compete against, you know, some other state that doesn't have a universal payer, then everybody's angry and we're not doing the mission that we want to do. So first and foremost, I think if we go into that, there's got to be, and you know, what that level of reimbursement needs to be, I think that could all be debated and we need to look at that. But I think there needs to be some assurance that it would be adequate and that Oregon would not be at an unfair advantage or disadvantage against other states. I think too, the other thing that I hear people get concerned about is just if it is a single payer and it's a government payer, that how political is that going to be? You know, are we going to have every election cycle, everybody pointing at the healthcare system, and is it going to change every 4 or 8 years? And you know, what does that mean? Because that's really disruptive. I'm a fan of the Affordable Care Act, fan of the CCOs that we have in the state of Oregon. I think they're both really good steps forward for Medicare and Medicaid. Are they perfect? No, but I think we need to build off those and continue to work on those. You know, to have, you know, like Trump said back in 2016 that we're going to repeal and replace. If ACA had been repealed, I believe that would have been a disaster in healthcare. And I don't know what we were going to replace it with because I never really heard a plan. But I think that political side of that makes me nervous. It has been interesting this presidential election season. Healthcare has barely been talked about, from my opinion. You know, I think Harris, everything I hear is a proponent of the ACA and thinks that we need to continue to build off of it, which I think is good. I haven't heard exactly how she wants to build off of it, but the fact that she wants to keep the ACA is good. Trump really hasn't spoken to it others than we need to make it cheaper. And, you know, he said he's not going to try to repeal it anymore. But I don't know. I think the ACA largely was insurance reform. And I think the change about insurance companies having to insure everyone regardless of pre-existing conditions was fundamentally a really, really positive step for healthcare in the country. So I hope we don't go backwards from that.
Excuse me,
Yeah.
did I hear you right that you don't think healthcare has been mentioned a lot in the latest election cycle?
It's been mentioned, but I think a fraction of what it has in prior elections.
Just to
Yeah.
clarify.
Yeah,
Is reproductive healthcare not healthcare?
it is. Yeah.
Is that not the-
Well,
a little bit?
I should, I totally agree with that. Yeah.
Just wanted to clarify.
Yeah. I was talking more in terms, I guess, what I meant is around the Affordable Care Act and the big, you know, healthcare reform
The
legislation.
Affordable Care Act didn't include reproductive healthcare.
Yeah, there's a part of, yeah.
Just checking.
And
I wasn't sure I heard it.
Yeah, no, that's a great question. And I also, you know, I think, that gets into the Dobbs decision and Roe v. Wade and the Supreme Court and yes, and I think that should be a huge factor in the election process. So I don't disagree with that.
Okay,
Yes,
just checking.
yeah.
I was surprised.
Yeah, go ahead.
Just to change the tone of the
Yeah.
conversation a little
Yeah.
bit. People have been talking a lot about drug costs
Yeah,
and the role of pharmacy
Yeah.
benefit,
Yeah, a little
Yeah.
louder.
and the role of pharmacy benefit
Yeah.
managers.
yeah.
Can you address that from the perspective of hospitals?
Yeah, it's like a black box. With the pharmacy benefit managers, it's this in between, it's really complex. I don't know if I even understand how all these relationships work. I don't know if anybody really does. There's the drug companies that are selling their pharmaceuticals to all the pharmacies, and insurance companies are basically paying them paying for it for their members. And there's this adjudication that happens in this black box about, okay, here's X amount of money and here's how it gets divvied up between the pharmaceutical company and the retail pharmacies and healthcare. And I don't think anybody really fully understands how much the PBMs are taking out of that. So I guess where I come at it is we need transparency on that first. I think just everybody needs to understand it. And they maybe provide, I think there's some value in those claims have to be adjudicated. So there's some value in it, but what we're all paying for that, is it the appropriate level? I don't know. I do think that, speaking to pharmaceuticals, that when I was talking about the inflationary pressures that we see, we've seen our pharmaceutical prices go up, 10, 15, 20, sometimes 100%, year over year. And it's suffocating. I thought that was a good step, that when Biden and Vice President Harris were able to, start negotiating with pharmaceuticals companies for Medicare pricing. Other countries like Denmark and places like that, they negotiate as a whole country for pricing, not only for drugs, but for medical devices and things like that. And I think they're able to, probably leverage better prices by doing that. Yeah.
Alex,
I don't wanna.
Yeah, go ahead.
Go ahead.
So I'm curious, as far as the difference in rates, Medicaid reimbursement versus other reimbursement, never just generally,
Yeah.
Medicaid's about like,
Speak up.
Medicaid's about like 70% of the total
Yeah.
average, and Medicare is about 80, and then private insurance is 130 years. And
Yeah.
all so if there's been talk on the Universal Healthcare Task Force, and then
Yeah.
now the governance board is working on a plan. They haven't really talked about that kind of stuff yet, but at least with the task force, they were talking about global budgets for hospitals. So I'm wondering, I understand that would probably, not make things a little bit more solid and not tenuous in your financing, but how would that address all the other problems you see, like if Medicaid reimbursement wasn't increased, but you had a global budget, would that be better for you, or wouldn't really matter?
Depends how it was set up, and that's an interesting question. Maryland has a global budget in their state, and it really actually kind of takes away from the discrete reimbursement, like the Medicaid reimbursement per service that you do. It's more like the VA, where they just say, we're going to give you X amount of money, and you just got to live within your budget for that year. And there's probably some algorithm built in that if a pandemic happens, or your particular population that you're serving, it gets sicker for some reason, that maybe there's some add-ons to that. I think most people in healthcare are open to that. I think it's understanding exactly how it would be defined and how it would work. A system like that would have been very helpful in the pandemic, especially in the beginning, because if you recall early on, actually, like in this part of the Oregon, we did not get hit that hard by the virus early on. We did not see a surge up front. But the governor, had the mandate where if it was a non-emergent procedure or elective procedure, we couldn't provide any of those services. So I remember sitting in my office at Good Sam one day after we kind of had we shut down in healthcare, and our parking lot at Good Sam, and you all know this, normally is packed. There's hardly a spot there. I looked out there and there was barely a car parked there. And I was literally doing math on paper. How many days will it be until we can't make payroll anymore? Because, with that slowdown, no revenue was coming in, but yet we still had 6,000 employees that needed to get paid. So that was a really stressful time. That's the downside of having what we call fee-for-service medicine, where you get paid for everything that you do versus a balanced budget. You know, I'm getting X this year, and if there's a pandemic, I'm still gonna get X. So there's not these kind of wild swings to it. So I think most are open to it. Yeah. The other thing that it does,
Profit and nonprofit alike.
oh, I probably the for-profits aren't open to it, but I don't know. I should say, I don't know. I don't know for certain. Yeah, but, I was gonna say something else there, but I think I lost it.
Well, correct me if I'm wrong, and there are like 16 hospital systems in the state, and is that right? And aren't most of them nonprofit? So
Yeah, well, there's more hospitals or systems in the state, but there's 15 CCOs. That might be what you're thinking.
Okay.
Yeah. Most hospitals in the state of Oregon are nonprofit. There's, I think, only two. The one up in McBenville is for profit, and the one in the Mackenzie Willamette in Eugene is for profit. Yeah, the rest are nonprofit. Yeah. But there's lots of for-profit multi-specialty clinics with ambulatory surgery centers and that kind of thing in Oregon.
Other questions? Yes.
Yeah, I got.
Speak loudly, because the mic,
Sorry,
speak loudly. 'cause the
oh,
mic-
okay, system, yeah. I got involved in this a couple of years ago in connection with the Corvallis Clinic.
Mhm.
They had sent out a letter to all of us saying, in effect, that unless enough of us who are on traditional Medicare
Yeah.
switch to Medicare Advantage.
Yeah.
They were going to become something called a non-participating provider.
Right.
Okay.
Yeah.
And I responded in I guess, a very heretical way. What non-participating provider meant, and I had to go to the internet and ask some people about this, it was that they would charge 15% more. And also they would bill the patient immediately,
Okay.
and then later they would work, Medicare would do whatever it is going to do or isn't going to do. Okay, anyway, my idea was go ahead and charge us another 15%. Okay? And wrote a letter, I can leave a copy with you here, right? Showing that if they did that, okay, they could relieve themselves of this financial stress that they were claiming to undergo. They were always totally unwilling to explain where they were suffering financially.
The clinic.
The clinic, yeah. So it seemed like this was a pretext for for the state allowing them to be involved in Optum Health.
Yeah.
Anyway, that's a side story. It's always struck me that it might be useful to simply for you to charge me more.
Charge you more?
Yep, I'd say another 15%. Just
Yeah.
charge those of us who are on Medicare a little more, all right? It helps you, you can provide better service. I would be much happier paying another 15% and getting better service.
I don't, honestly, I don't know if Medicare would let us do that. And I don't know how the clinic was doing that. I don't know.
They just claim they could.
Oh, yeah.
Because part of the Medicare regulations is that what we get reimbursed through Medicare, and then if there's like a copay, we need to accept that as full payment for services. And I see Mike done, yeah.
I'm freer to speak than you are. In that case, the Corvallis Clinic was lying.
I don't know that's the circumstance.
I know you
Yeah.
But one or the other,
Yeah.
okay? If they
Yeah.
legally couldn't do it, and they're threatening us with it.
Yeah.
Now, this would be, I think I probably am in a very small minority.
Yeah.
In taking this position. You'd be doing, I think, what is best for people, which is sometimes very different from what people want.
Yeah. Because that is, therein lies the dilemma I said before, is that with Medicare and Medicaid, we can't negotiate that. It is what it is, so it does become harder.
That's right.
yeah.
The question would be whether
Yeah,
Corvallis Clinic was lying or whether there is a different category.
could be. Yeah,
Throw it out. I'll leave this with you.
okay, all right, thank you.
I'd pay 15% more if it kept you from being bought by Optum.
That was the point later on.
Yeah.
We'll all gather together and pay you not to become part of
Hey,
Optum.
throw something in there. If it gets bought by Optum, you're gonna wind up paying more
Yeah.
than 15.
Right,
right.
What's gonna happen is some people are gonna pay too little, other people are gonna pay way too much. And you've got all the anxiety and frustration trying to figure out which of those two categories your next bill is gonna be.
Yeah, yeah.
We have a question over here.
Yeah,
and then
before,
one over.
can I follow up? Cause I lost my train of thought before and there's something I want to say and I just remembered it. Going back to the balanced budget. So one thing I'm a big proponent of, not everybody, I don't think Dr. Huntington agrees with me on this, but I think, what makes a bigger difference is not who's paying us, whether it's a single payer or who's paying it. It's how they pay us. And I think with the balance, like with the budget payment, that money is in a sense kind of prepaid and we get X amount of money. And then what's our incentive after that? It's okay, if we keep everyone healthy, then we're gonna come in under budget. That seems like those incentives are aligned in a good way. Versus the traditional fee-for-service medicine. So if I'm a primary care doctor and I provide a service, you owe me $80 for that one little service. That promotes productivity, volume, right? And you gotta have a lot of volume. And what absolutely morally, I just have always had a really hard time reconciling this in my head. That Samaritan or the clinic or any other healthcare system is gonna make a lot more money the sicker their community is. Because if they're paid based on volume, the sicker the community is, the more services that they need. And that just seems absolutely fundamentally wrong with our healthcare system. If it was a budget, it's a flat amount and the incentives are to keep people healthy then. And I think in some way, we gotta change our system at some point where the incentives are in the right spot. So, go ahead, sir.
I think I'm going to have trouble with finding.
Oh, yeah.
Excuse me. I think in that argument, you're going to have some problems defining what you mean by wellness or a healthy community, because that varies from, like, do you have baldness
Yeah, sure.
treatments versus cancer chemotherapy,
Right.
that kind of thing, and that's
Right.
always been an issue.
Yeah.
I would like to ask you if you'd be willing to share your relationship with the physicians
Mhm.
and vis-a-vis the management of the business of medicine. I mean, historically, physicians were kind of self-employed,
Yeah, sure.
local, and they merged
Yeah,
together.
yeah,
You know.
yeah.
I was actually part of the Lebanon physicians that
Oh,
joined
nice.
the original Samaritan
Nice, yeah.
way
We
back when,
work with Rick Wolpat.
way back when.
Yeah, yeah,
Uh-huh.
yeah.
Well, if you really want to. Thing is, I can say, I helped recruit, Dr. Kosmala.
Oh, yeah, yeah, yeah,
Didn't know what happened to her.
Yeah.
Retired a couple of years ago.
yeah.
All right, no, what do you think about, and what do you feel is the feeling among the physician community in terms of what they would like about the business, vis-a-vis things like, do they want to do more procedures and be paid per procedure, the classic RVU story? Or are they interested in managing a more global healthcare network for, the great health? How much do they get involved in these decisions?
A lot. We have, in the last 3 or 4 years, we've built up, we didn't historically have this, what I call like a formal clinical leadership structure. So we have a chief physician executive for the system now. We have a physician that oversees population health for the system. We've got senior medical directors that are all clinicians, physicians, or APC or APPs. And I think it's a great question, because I think if when I first got into healthcare, generally the doctors did not want to move off of fee for service, right? It was comfortable, it was somewhat predictable. I think especially, I'll pick on the specialists a little bit. What was your area? I'm just curious. Pediatrics, yeah.
General.
Yeah, I think like with the, orthopedic surgeons, volume. But I gotta say, I think as physicians have felt more and more being kind of on this productivity, fee for service hamster wheel, feel like it's this constant, like, how much can I churn out versus is the patient actually getting better? And I think for a lot of the, was it the ICD-10 codes? I think there's something like 84,000 codes now. And literally there's
Oh,
a code, there's a code for getting struck by an orca or getting poked by a turtle. I mean, like, these are real codes. And, what I hear the doctors say is, I just want this simplified and I want to be able to leverage my care team. And there's so much pressure on the individual doctor to do the service, to do the documentation. And I think not 100%, but I'm hearing more doctors say, I'd rather work as part of a care team, really trying to impact the health of the patients. And frankly, I hear most doctors say, I don't even want to know whether it's a Medicaid patient or a Medicare patient or commercial insurance. I just want to provide the same care that I do to all patients. And I think we've all paid more attention to the Kaiser model. And Kaiser model is prepaid healthcare. And it's more, they get their premium and it's more like a budget. And generally the satisfaction of doctors working with Kaiser seems like it's pretty good. It's not perfect, but that's just what I'm hearing now. It's not 100%. There's, and it probably varies around the system to some perspective on depending where you're at. But those are the types of things that. What?
Could have been worse. I could have asked you about, is gender affirming care part of healthcare too? In the election.
Yeah, but what's your angle on that? Just,
Well, I
is it-
just think
should-
it's been part of the current political
yeah,
discussion
yeah,
that I would include in healthcare.
yeah, yeah.
Okay,
yeah.
okay.
Yeah, no, I'm sorry, I was focused on the Affordable Care Act as the context of that, but I get what you're saying, yeah. Yeah, good.
Mike.
Yeah, speaking of Kaiser, they seem to have a system that balances incentives well. They get a salary and then a chance for a bonus.
Yeah.
And the bonus,
Well, I don't know all this, Mike, but yeah.
well, what I understand is the bonus depends on two things. If they don't order enough tests, people
Yeah.
get sick and they cause a lot of expense. in the
Yeah.
System. If they order too many,
Yeah,
it's the same, but they balance each other and it's not a huge part of their salary either. It's a bonus at the end.
yeah.
Does that sound like a good idea? Or can you do it in the kind of system you have?
Well, it's, I think if, what I hear from the doctors, and I practice law for a while, and in law, you keep track of every 6 minutes of your time and then you bill it, right? So it is all based on productivity. So I get that. If you're a doctor right now under the current model where it's fee for service and you're working really, really hard and you have another doctor over here that's working okay, average. I understand why that doctor that's working really hard and really productive wants to get paid more based on that. Now, if it's more of a budget, doctors can still work really, really hard, but it's not all based on this productivity and fee for service model. I think I don't know, I haven't worked for Kaiser, but it seems to be there's a less emphasis in that context than there is in the normal system. Kaiser's not perfect. I will also say this. Kaiser, they do a lot of great things and I like their model, but they're really not seeing the uninsured or Medicaid either. Their target is, because again, they got more of a budget. Their target is large employers with young, healthy people that don't get sick. Cause then they get this premium revenue, and they don't provide a lot of services and then that's how they, make their money. So but the model is, yeah. See why it works. Yeah. Yeah.
Alex.
Yeah.
Sorry. So you mentioned workforce shortage as being a
Mhm.
problem,
Mhm.
and I'm wondering, because my GP is with Samaritan, I'm very happy with, by the way. But we have friends who are at Corvallis Clinic
Yeah.
and have lost because of what all's going on at Corvallis Clinic.
Yeah.
They need GPs.
Yeah,
And so I've been recommending my doctor, and there's like a 6-month wait for anybody to see anybody.
Yeah.
If they can even get in.
yes, yeah.
So what I'm wondering is, what, with all that's going on with the clinic now,
Yeah.
is this gonna, how do you see that shaking out or impacting Samaritan? Or, I mean, is there a pipeline to rectify this? Cause it seems like it's gonna get worse.
It's gonna get worse.
probably.
It's gonna get worse, I think, yeah. I worry. I just want the clinic to be stable. I really do. If we have more physicians leave the community, that is gonna stress an already stressed access problem. And there's an access problem all across the state, so we're not unique in it, but I think if the clinic continues to struggle and doctors leave, that's, it's gonna hurt. So pipeline, we are fortunate that we have the medical school in Lebanon. They're graduating about 100 doctors a year. And many of those students do their rotations in our hospitals. And then we have a residency program. So once you graduate from medical school, then you most often do a residency. We, at any given point in time, we have about 110 residents in our system working. That's actually the second largest residency program in the state of Oregon, just second to OHSU. So it's a relatively new program though. So, it takes a while to really build that up. We would recruit a ton of primary care, pediatricians, psychiatrists tomorrow if we could, but it's going to take some time to get folks in. Yeah.
We have a
But-
question online. Debbie Alba, if you take yourself off mute and ask your question.
Yeah, thank you. Yeah, hi Doug. I'm a nurse practitioner, and so I work under global billing. And I am the challenge with global billing, kind of going back to what we were talking about before, is that it doesn't accommodate for risk and people that are needing a higher level of care and more time in the office. You just get paid one amount, and you don't you just hope that it all kind of balances out your low risk, high risk spread of population. So I'm a little concerned about like going down that pathway with just kind of this global, reimbursement. And I've been kind of intrigued by what OHP has done with the waiver 1115 and looking at healthcare a little more broadly. Knowing that, you're a public health guy, so it's, what we see in the doctor's office really only is about 20% of the impact on the health outcome. The majority of it is social determinants of health. And
Absolutely.
so I'm wondering, given kind of all of the increased complexity that we're seeing in our patients right now, what role do you see like Samaritan and these healthcare organizations as far as kind of going down this path of the waiver 1015, which is looking more at like housing and, making sure that people have their basic needs met, which is, going to impact their health.
Yeah, I think the maternity care, the kind of global billing or the bundled payment you're talking about, I think, I don't know how well that has worked. And I could sense that you don't think it works that well. And I think what's hard about that, it's like you've got this one little area where we've got this global payment that's kind of dropped into this larger fee-for-service environment. And I think what's happened is those rates have actually just gotten behind over the years. That's why we see hospitals and clinics around the state stopping some of these services because they lose money every time they do them. And the malpractice risks are really, really high on that work. And it's a high risk area. So I think if, and again, I'm not necessarily here advocating for a global budget, but I think it's an interesting concept. I think there's some merit to it. I think it would work better for maternity care services if the other services were under that as well. And then you could kind of look at the entire system or region and, you know, we got to provide all these services under a fixed amount versus this one little discrete area. So I hear you. On the social determinants of care, I think, or of health, I think that is important. And what you said is exactly the data I've looked at, is that the actual medical care that we provide really only impacts about 20% of someone's overall health. And there's so many other things that go into it. I do worry that traditional healthcare systems get so preoccupied with some of that we also, you know, we're not taking care of people when they're sick or injured. So I think there's a balance to all that. I think what I learned during the pandemic was our public health departments in our counties are way underfunded, and we really need to build those back up again and work in partnership with our local clinics and our local healthcare system to really think about public health and population health and some of these other things around housing and food insecurity. But I am worried if they just say, we're just gonna have healthcare take care of all of it, because we're not experts in housing. We're not experts in how to run a food bank. There's a lot of things we're not experts in, and we're gonna have to rely on public health organizations, other nonprofits that do that kind of work.
And maybe county commissioners who don't defund their own county health department.
Yeah, I think those are crucial. I think the county health departments, I think the federally qualified health clinics that we have in the counties, I think those are all critical components of the care.
Or just a point of clarification, just on the global budget, what I was referring to was just with respect to the last question, when the task force looked at it, they were looking at just hospitals.
Hospitals, yeah.
Not clinics or individual, you know,
Yeah.
groups of
Yeah.
doctor groups, so.
Yeah, and I know, I think, was Warren on here? Yeah,
Yeah,
I mean, I consider him to be the foremost expert on some of that stuff. He's pretty amazing, yeah.
been surprising.
What'd you say? He's not?
I'd say our Warren.
Yeah.
A member in good standing.
I show up when people say nice things about me, Doug.
Yeah, thank you. I wasn't sure whether you were even on. I saw your name earlier, but I rely on him for a lot, actually.
Yeah, we all do. Mike.
Yeah, I just wanted to reassure you, Doug, that the existing Medicare for All bills, that actually should be called Improved Medicare for All.
Yeah,
And they do, bring the salaries closer together over time,
yeah.
emphasizing primary care.
And they've been moving in that, yeah,
Yeah,
moving in that direction.
and the bills also, contain funding for, transition of, jobs. If I'm a clerk in an insurance industry, then there's training, to deliver care instead of deny care. And also paying for, medical education. So those are all
Yeah.
part of the bill. And then there's a transition, that they would cover also. So they're thinking ahead.
Yeah,
It's not gonna be existing Medicare for all.
yeah,
Karen.
The Oregon Health Authority has several programs, both for licensing of doctors from other countries and trying to develop the workforce. And as we can see from the shortages, apparently those programs are not particularly effective in increasing the numbers of people who are working in these needed areas. What can or should the state be doing to really improve the workforce situation?
well, for doctors, they've done some of this, but I think they need to continue to provide financial incentives for, you know, like waiving of student loans or things like that to get doctors to practice in rural areas. I think that helps. I've seen in my time, there's been more of that and then less of that, but I do think doctors will respond to that. Not all, but some. I do worry about the more rural parts of Oregon, long term, and telemedicine's one thing I can kind of help, but there's nothing like a doctor, you know, being in a room and being able to lay hands on the patients. And I'm afraid that I don't want to lose that experience in those rural settings, so I do worry about it. Yeah. And you could do the same for nurses too, you know,
Yeah.
student loans. PAs, physician assistants, nurse practitioners. Oregon already allows them a fair amount of independence. I think they're part of that care continuum. I think the state has been allowing pharmacists to maybe expand a little bit. I think it's getting some of these clinical types so they can work at the top of their license. And then too, a question I'd have is, I hear this more and more from doctors, is that, other countries seem to kind of, you don't necessarily even have to get through an entire undergraduate, 4 or 5 year degree and then go to medical school. Is there a way to combine some of this education that would allow a little bit faster throughput for our doctors and not have the time and the huge financial commitment to get all the way through medical school and then residency program? I think we need to look at the formal education process that we've had for a long time and really ask ourselves, is this all necessary? Maybe it is at the end of the day, but I don't know. I think it's worth asking. Yeah.
You need organic chemistry. I'm just saying.
Yeah.
Be a good doctor.
You had a question?
Yeah. Okay, get somebody else and then give me a minute to.
Okay.
Okay.
Uh,
What are your thoughts on the medical
I'm ready,
education?
Joe.
I'd like to hear.
Well, my father started out as a high school chemistry teacher.
Yeah.
And his brother talked him into going to medical school after the Korean War on the GI Bill.
Yeah.
And he was one of the very first physicians. He always kept his teaching license, which was rare in a medical school.
Yeah.
But
Yeah.
he was one of the first people to hire nurse practitioners.
Yeah.
When I finished my medical career at the hospital in Bethesda, the National Institutes of Health,
Yeah.
named for Senator Hatfield, by the way.
Yeah. Yeah.
Oregon.
Yeah.
The patients were almost exclusively cared for on the wards by nurse practitioners instead of hospitalists, and that worked out very well.
Yeah.
On the other hand, they were some of the best educated.
Yeah.
You kind of get the cream of the crop, and so
Yeah.
can you generalize any of those
Yeah.
solutions? In 1900, there were 10,000 medical schools in the state of Ohio alone, and
10,000
10,000
medical
and, The
schools?
joke was when the third doctor moved into the same town, they founded a medical school. University of Richmond Medical School in the 1890s was a 6-month course after high school, and the advanced course was to take the first 6 months twice.
Yeah.
So they sent around a guy named Abner Flexner, and he went around the country and produced a report. I actually read it myself. It is entertaining as hell.
Yeah.
If you come from Buffalo, because they mentioned, in spite of how well physicians do who come from fourth years, from medical schools associated with 4-year undergraduate universities, there is the University of Buffalo. But that's actually the start of that chapter.
Yeah.
The point is that he was able to prove one thing, that physicians trained in a medical school affiliated with a 4-year undergraduate university killed fewer patients. He did not prove that they had a better outcome, just killed fewer.
Yeah.
From that was enacted the beginnings of the general medical education, and a Canadian physician by the name of Osler, who developed a system of training physicians that is the apprenticeship that is continued to this very day.
Yeah.
So we live with that history.
Right.
You can throw in the Salt and Illinois disaster in 1938 that caused the Pure Food and Drug Administration Act that got the FDA going.
Right.
And you can actually get into all the pharmaceutical issues
Yeah.
from that history as well.
Yeah.
So all of these things led to a comfort zone that was the see one, do one, teach one apprenticeship model of modern medicine that I certainly went through and trained my share of docs with too.
Yeah.
How well that will extend into the area of AI, especially with things like automatic readers, and electronic medical records and stuff. You could look at what Newt Gingrich said, that was going to cure everything as soon as we computerize all of it. Really. So there's a ton of history in all of this, which I've already bored you with. And it's much more extensive. I think that there's certainly an obvious sort of top level down observation, which is there are other countries like Denmark and some of the Norwegian countries, and certainly you can start to talk about Canada, who seem to be able to do this without spending less of the gross national product. Now, they didn't put a man on the moon or invent the microchip, you could say, or sequence the human genome. And so that's always the counter argument. But, if physicians are trained, they tend to be the A students and they have brains in their heads, so they aren't really great widgets like factory labor per se, but they are an asset, I suppose, if they apply the thought that somebody's got to pay the light bill and the water bill. Most hospital administrators come from a nursing background, not from a physician medical background, by the way, which I always thought was very interesting as well. I don't have a clue. I love the history of Dr. Virchow, who was, there's a Virchow archives that physicians, especially surgeons who tend to be conservative, admire and talk about Virchow. He was actually a flaming communist radical in Germany. I always loved his last line, which is politics is the endeavor of people to better as a group, and medicine is just politics on a much larger scale.
That could be.
We have a question back here, or?
Yeah, change the subject a little bit. From what I've read, one of the primary concerns, problems that physicians have is with the amount of time that they have to spend sitting in front of a computer.
Absolutely, yeah.
It's just, from what I read, it's just driving them crazy.
Yeah.
And there's a huge system, Epic.
Yeah, we have it, yeah. Epic it's based in Verona, Wisconsin, which is right outside Madison.
It's a
And
huge campus.
I always say, if you want to know where all the dollars have gone in healthcare, go back to Verona, Wisconsin, because it's this huge campus. They have like a 10,000 person auditorium. They have like a Hogwarts castle there now. It's unbelievable. And it's all owned by one lady.
Right.
Yeah.
Multi-billionaire.
Yeah.
So the concern is that that's sucking a lot of money.
Yeah,
That could be, used to provide
Yeah.
health care.
yeah.
And it also provides, often whoever in the healthcare organization with a wonderful tool for miscoding. The coding procedures that aren't cut, so they're not covered by Medicare, upcoding, all kinds of very clever methods for extracting more money from the patients. Any thoughts on that? Oh, Lex.
I would, if I hear any common big dissatisfier in the practice of medicine from doctors, it is the documentation in the EMR.
Right.
It is over and over again. And because of it, they're not able to interact with the patient and look the patient in the eyes and, they're actually maybe light at the end of the tunnel on this one. I'm more optimistic about this than I have been in a long time. I think we're still kind of waiting to see how AI is really gonna help and where it's just hype. But we've been test piloting this new, it's called this DAX program that was developed by this company Nuance that's owned by Microsoft, and they took the ChatGPT large language algorithms and put it into this. It's an ambient listening AI. So when the doctor starts seeing a patient, they literally just start their iPhone. You have to get the patient's permission. Doctor starts the iPhone and he can just talk. Now he or she has to talk about what they're doing. But this AI program has the ability to listen to not just like transcribe it, but actually put different thoughts together and put together like a chart note for the physician.
Right.
It is not maximized yet, but it is truly amazing what we've seen. Like the doctor can be talking to the patient. I've literally seen this happen where then someone comes in and asks the doctor, hey, we're getting pizza for lunch. Do you want some? What do you want on the pizza? and then the doctor's talking to the patient about, you know, bullying, all this stuff going on. None of that shows up in the transcription,
Yeah,
and it's
right.
all organized in next steps. It's not telling the doctor what to do. It's not
Right.
practicing medicine. It's just smartly hearing what's going on and packaging it together. The doctor still has to review everything. The doctor needs to make sure that it makes sense. But at least the first draft is all done.
It would save the doctor time.
Yes, and we're test piloting it with 25 primary care doctors right now. Doesn't work for all of them. They, you know, the dictate, you know, they just it doesn't work, but for a majority of them, it's saving a huge amount of time.
Wonderful.
Yeah, go ahead.
And I'll just warn everybody, we got about 10 minutes, but, Mike, I guess, has the next question.
I've had experience with Otter AI over the past 3 months. It has saved me hours of time
Okay,
in planning. Of getting summaries like you just mentioned.
yeah,
A meeting that goes an hour long. And it will, it takes about a minute to upload, takes about 15 minutes to do all the transcriptions. You identify who's the speaker and it'll remember that forever then. So then when you get a transcription, it tells you who said what, and it'll give a summary. And, you take it and you have to download it and edit it, but it is wonderful. And then the other AI is Perplexity for answering questions. That's saved me hours also.
yeah.
So I'm glad you're already working with it.
And we have not studied this. There are other companies that have already studied it though. And I guess most importantly, at the end of the day, the patient feels better about the interaction. They feel like
Yeah.
the doctor's really listening. Yeah.
Any,
Gentleman on the end.
yes,
Make this quick. This is an AI comment. I've been a translator all my life, working with large volumes of written and spoken language. I started literally before email and kept on working into the AI era. Through the development of AI, there was a time when 95% accuracy was considered good. 99% or 98 may be the standard, but the longer that conversation goes on, that 1 or 2% multiplies. And just after a certain point, inaccuracy is guaranteed. And when your AI is dealing in the realm of light housekeeping and translated as light housekeeping, it automatically goes off the rail with the fuzzy logic. Now, that's less likely to happen in a clinical situation, but people do talk about ships and sails and sealing wax and all that. So I'm simply worried, is there someone in line who can bring the train back on the rail in that AI context? Does a human look at it at some point?
Yeah,
Yeah,
yeah, definitely.
Well, in the context of it, the doctor still owns the note.
the
So,
doctor owns the note, so does doctor have time to read it or even be paid for reading it?
well, what the doctors say, it takes him way less time to read it than to draft it. So,
Right.
so, yeah, that's how, they look at it. What's also interesting, is how many errors would the doctor or nurse make typing?
Right.
And-
They would be of a different nature,
Yeah,
entirely different.
yeah. But I agree, there's definitely a risk to it, and, at least with this you know, and it's also, it sounds like you know a lot about this, but with AI, it's also kind of what you're exposing to the AI, and they've got this really like tight box where they're not letting it like learn from just everything on the World Wide Web. Cause then it learns all kinds of crazy stuff. So, it's interesting. It's a whole new way of thinking about things, I guess. But definitely risk, yeah.
any last questions or comments?
Just thanks.
Thank
Yeah,
you. Thanks for having me.
This-
Yeah.
This was
yeah.
just wonderful.
Yeah, thank you. Thanks. I appreciate it,
Well, we appreciate you.
and appreciate your support in the community and everything you do, yeah.
Yeah, we haven't asked you what we can do to help fund the hospital, but maybe that's maybe next year.
Yeah, talk to Sarah Gelser, talk to those guys, yeah.
Yeah, okay.
We actually have, I think, in our 3-county area, really good legislators that are really trying to help healthcare.
Yeah.
Yeah.
That's been our impression. We've had most of them, I think, speak to us over the last couple of years, and it's been impressive, so.
Yeah.
All right.
Okay.
I think folks, I know some of our officers are not here tonight. I think we're gonna forego officer reports and committee reports unless there's somebody who is going, oh my God, I've got to make a report on something, but hearing none.
You want me to leave for this? You,
Oh, no,
yeah,
I think
yeah.
I'm just gonna call it.
okay,
to
all
an
right.
end. Let's call it a night, and thank you everyone for the
Thank you.
questions and the discussion. It really has been very stimulating and wonderful.